This is a talk about feeling uncomfortable, about trying something new. And in the spirit of feeling uncomfortable and trying something new, I stand here before you today completely out of my element. You see, even though I applied to give this talk, when it was accepted and I received that email, this is what I thought. At this point, I think the only remedy for this feeling is to get through the next 15 minutes or so. So here we go. First, a little bit about me. I'm a genetic counselor who specializes in cancer genetics. And I used to work in clinic and currently work for a genetic testing laboratory. I fit the genetic counselor mold to a T. I love a good to-do list. I love spreadsheets. I love plans and schedules and being prepared. I have a truly unnatural love for Post-it notes and highlighters. But in my personal life, this characteristic of mine drives my husband crazy. He makes decisions by thinking about what will make for a good story when we're 90 years old sitting in our rocking chairs. I make decisions with pro-con lists. So my love of all things predictable and planned and put together is literally put to the test every single day. But more specifically, it's put to the test every Sunday. You see, 12 years ago, my husband and I started having weekly experimental dinners with our good friends John and Sasha. There's only one rule for experimental dinner. You have to make something you have never made before. That's it. That's the only rule. We alternate houses. We alternate who makes the main dish, who makes the sides and dessert. But the only rule we care about is that you make something you've never made before. So every Sunday, I get a little uncomfortable. Every Sunday, I try something new. And like I said, we've been doing this for 12 years. And this is a big deal for me because I am not an adventurous eater. I don't think I ate a salad until I was well into my 20s. Yet, since beginning our weekly gatherings, I have personally cooked and eaten Turkish eggs and lamb chops, stuffed acorn squash with mushrooms and feta cheese, roasted Brussels sprouts with bacon and lemon rind, and we've even made saag paneer from scratch. So now you're wondering what on earth this has to do with genetics. I wish I could tell you that experimental dinner was a flash of genius. It wasn't. It came from a place of need. When we first started our Sunday gatherings, our friend John was being deployed to Iraq, and John and Sasha had just had their first child. Experimental dinner filled our need to take care of our friend Sasha and her daughter while her husband was deployed. I would argue that today, we're in a similar place of need with respect to genetics. There are fewer than 4,000 genetic counselors and fewer than 2,000 medical geneticists in the United States. A recent analysis suggested that we won't have enough genetic counselors to serve the population until 2024. And that's based on the state of genetics today. It does not take into account the fact that 90% of individuals who are at high risk for hereditary cancer aren't appropriately identified. Or that non-invasive prenatal screening should be offered to all pregnant women, not just those at high risk for chromosome abnormalities. Or that there are 10 new genetic tests that enter the market every single day. So how do we as a profession bring these two opposing trends together? Are we mediators or are we barriers? One option is to do what's comfortable, to work as hard as we can to ensure that patients have access to genetic counseling provided by trained genetics professionals. Traditional models of counseling are still common for many genetics providers. They bring patients and providers together in clinic or even via telephone. And yes, I just called telephone counseling traditional. The reason I consider it somewhat traditional is that other than the obvious fact that the visit occurs over the telephone, it more or less looks like a visit that would occur in person. And yes, it increases access and convenience for our patients. That's a good thing, but it doesn't address our workforce issues. So, what exactly do we know about doing what's comfortable? What do we know about traditional models of genetic counseling provided by trained genetics professionals? Well, one study showed that women who underwent genetic counseling for BRCA1 and BRCA2 with a genetic counselor had increased knowledge compared to women who did not receive counseling. We also know that non-genetics providers occasionally make mistakes when ordering genetic testing. And we have collected these cases. We've even published on them in an effort to encourage other providers to utilize our expertise. A few years ago, we were rewarded for these efforts, and some health plans now require pre-test genetic counseling provided by an independent genetic counselor or medical geneticist as a form of prior authorization. Case closed, right? Sure sounds like we're necessary mediators, and we better get really busy training the next generation of genetics providers. But what if we looked at this from another angle? Let's take the study I mentioned just a moment ago, the one where women who underwent genetic counseling with a genetic counselor for BRCA1 and BRCA2 had increased knowledge compared to women who didn't receive that service. The knowledge that those women had included knowing the exact likelihood that a sibling would test positive if they themselves were found to test positive for a BRCA mutation. It also included knowing the frequency of BRCA mutations in the general population. But why is that the measure of success? Is that what we're really concerned about? That women, especially those who test negative, can pass a multiple choice test 6 months or a year after having testing? Shouldn't we instead be concerned with whether those women are following appropriate management guidelines? I also mentioned that we've collected all the cases where non-genetics providers have made errors in genetic test orders. Interestingly, I've never seen us put together a collection of cases where genetics professionals have made errors. So I'm going to go out on a limb and share a personal story. When I was in clinic, I met with a woman who had a significant family history of breast and gynecologic cancer. And she was not sure whether those GYN cancers were ovarian cancer or endometrial cancer or cervical cancer. My typical line of questioning was not helping. Now, this is back in the day before panels, so my only option was to order single gene testing. As you might expect, I ordered BRCA1 and BRCA2 testing, and as you might expect, it came back negative. That's it. That's all I did. I didn't order any additional testing. Honestly, I wasn't convinced that she needed any additional testing. And honestly, I just wasn't sure that we were going to be able to get insurance coverage for any additional testing. A year later, that woman came back to my clinic. But now, she had the genetic test results from her sister. Those results showed that there was a P10 mutation in the family. My patient was understandably less than pleased with me. But I learned from that experience. I learned to ask more questions. I learned to slow down. I learned not to make as many assumptions. So rather than chastise others for potential errors, what if we instead taught them how to do better? And finally, I mentioned pretest counseling. The goals of pretest counseling are commendable and worthy and rooted deep in our profession. We want patients to understand their options for testing, including the option for no testing. We want patients to understand the risks and benefits, the implications for family members. We want patients to have a place to wrestle with what a genetic diagnosis might mean in their life. But it turns out that mandating pretest genetic counseling may have some unintended consequences. In one study, a quarter of individuals who met NCCN criteria for hereditary cancer testing didn't follow through with mandated pretest counseling and had their tests canceled. And I deeply empathize with these patients because I too hate jumping through hoops to get care. When I was pregnant with my second child, my OB dutifully informed me that I should go get a flu shot. She also informed me that she didn't have any in her office. Guess what? Never got that flu shot. So now the water's a little muddy. Are we necessary mediators? Or are we barriers? Meanwhile, many alternative service delivery models are being investigated, but these make us uncomfortable. They range from interactive computer programs to pretest education videos to genetic counselor extenders, online results delivery, chatbots, even direct-to-consumer models. I'm going to take just a moment to discuss a few of these in more detail. First, genetic counselor extenders. A genetic counselor extender is another medical provider, often a nurse, who is trained by a genetic counselor to provide a limited scope of genetic services. More complex cases can still be referred to the genetic counselor, or the genetic counselor might act in a consulting role. And it turns out this could be an effective model. In a hospital system in Indiana, 4 times as many patients were able to access genetic services when nurse navigators were trained to perform basic risk assessment and offer BRCA testing. Now you're saying, okay, that does not make me uncomfortable. I am just fine with that. But consider, how would you feel if the nurse navigators weren't limited in their scope? Or if we're really just training ourselves out of a job? So I'm going to ratchet it up a few notches here, and we're going to talk about chatbots. A chatbot is a computer program designed to interact with patients on their phones via text message or chat message. The chatbot does not tell you it's a chatbot. It interacts with you just like a real person might, and in fact, it chats with you just like a genetic counselor. It can do this because the computer programmers have observed genetic counselors in clinic. Admittedly, there are not many studies on chatbots, but there are studies showing that computers can educate patients about carrier screening, BRCA testing, and even disclose low impact or mostly negative genetic test results. What's more is that some of these studies show that the computer can do this just as well as a genetics professional. Still not squirming? What if the computer disclosed high impact or positive results? Which brings me to direct-to-consumer models. Now, I know you're all familiar with direct-to-consumer models because we collectively became unglued last month when a certain company began offering Ashkenazi Jewish BRCA mutations direct to consumer. To be fair, we did not write all of these headlines, but we are quoted in many of these articles. And it really does not appear that we had anything nice to say about this new offering. So why do some of these models make us so uncomfortable? I think it's because of some of the unanswered questions. Who will take the family history? Will they do a good job? What about informed consent? What about VUS results? Can patients really handle this information without us? These are important questions. They truly are. And we in the genetics community are in the best position to be asking them. But let's make sure we're really asking. Let's make sure we're not just criticizing or jumping to conclusions about the things that might go wrong. Let's not be barriers. Today, I'm urging all of us to take a new perspective, to consider, and yes, of course, study, the things that could go right, to be necessary mediators, even when it makes us uncomfortable, to get in that kitchen and make some Turkish eggs and lamb chops. So ask yourself, am I a barrier or a necessary mediator? If we don't start asking ourselves, somebody else will, and we might not like the answer. Thank you.